Welcome to the Crescent City, where Vital Options is in New Orleans with ASH, the American Society of Hematology. Dr. Stewart, what is the role of the chemotherapy? Is it still a cornerstone, and how do you use older chemotherapeutic agents in combination perhaps with some of these new targeted therapies?
Well, we're in evolution. I think for many cancers, the first-line therapy, particularly in acute leukemia and lymphomas, is still based on older chemotherapy technologies, and the newer drugs are tending to come in a little bit later in the treatment at relapse. But that's changing very quickly, and I think, for example, I talked about chronic lymphocytic leukemia earlier, and it looks like at this meeting there will be a paradigm shift in how that disease is treated, where a targeted therapy will be introduced almost immediately. In myeloma, we've been using more targeted therapy already for the last 5 or 6 years. So it's shifting sands right now, but there's a role for both. I think patients shouldn't feel that the older chemotherapies need to be abandoned, or bone marrow transplant needs to be abandoned yet. We're not good enough to do that yet. Those are still important treatments, and the newer therapies are really just getting off the ground now.
And what about the role in pediatric hematologic malignancies?
Many of the pediatric blood cancers are the most curable cancers there are, and most of those cures come from conventional old-fashioned chemotherapy. So there particularly there, I think it's been less of an imperative to find therapies which are targeted, because it is so I mean, childhood acute lymphoblastic leukemia is curable in 80 or 90% of children. Hodgkin's lymphoma is curable in a large percentage of children and young adults. So with old-fashioned conventional chemo, the problem has been beyond those diseases when we get to acute leukemias and myeloma and many lymphoma types, that those conventional chemotherapies we've tried for decades, we're not getting there.
Exciting on one hand in the pediatric space. I mean, you went from the 60s with a 3% cure rate in pediatric ALL to greater than probably 90% today. But I do think, it remains a challenge, because I think it's a difficulty that we see for our patients. It's a wonderful thing to say we have long-lived survivors, but they're dealing with a lot of challenges from the toxicities of those treatments. And so we continue to sort of look for paths for these innovative therapies to think about, are there ways that we could soften the treatment and still see that kind of cure rate? And I think that's where these really targeted, wonderful new therapies that we're hearing so much about are so exciting for patients who are seeing those 20-year down the road delayed onset effects from their early treatment.
Chronic myeloid leukemia is essentially cured by a single drug taken daily, whereas when I trained 10, 15 years ago, it was essentially incurable without bone marrow transplant. So we tend to forget that one, but it's the poster child of the genomic era, even today.
Thank you, all of you, because you are working in a most exciting time. We wouldn't have had this discussion 20 years ago.